dual fertility doctor and expert virologist. And she also has some Trini roots, so that's why thought it was so special to have her to speak tonight about PCOS and to answer a couple of questions and to talk about a little bit about some of the facts, misconceptions, types of PCOS and whatnot. And she has been doing so much. She is part of the Dynamic Uterus movement, who they really talk about the capabilities of our hormonal system, our the uterus, and our microbiome. And she has a specific segment on Wednesdays talking about PCOS, and I would listen in, and there's so much information that she shares along with the other speakers, and they help so many women. So I'm so glad to have her tonight. So I'm just going to bring her up.
Hi.
Hi, Dr. Cindy. Thank you again for joining me.
Thanks for having me. It's a pleasure, and congratulations on successfully completing and pulling off the summit. This is a huge milestone.
Oh, thank you so much, and I'm so grateful for places like you who agreed to be part of it, because I know you all are so passionate about helping women and really sharing that information about women's health and these things, which is so important to talk about right now.
True. Very true.
So, Dr. Duke, for the audience, I just wanted to get basically your take when you have to describe what the condition polycystic ovarian syndrome, how would you describe it?
The first thing I start off with is the fact that the name is actually very misleading and oftentimes causes more problems than not. Because even though we call it polycystic ovarian syndrome, it's not cysts, right? There aren't cysts on the ovaries. It's actually lots of tiny egg houses known as follicles. So in reality, it should really be called polyfollicular ovarian syndrome, because when you look on the ovaries, we're not looking for cysts, and usually we're not going to find cysts when we're looking to make the diagnosis. What we're really looking for is an abundance of egg houses or follicles. Specifically, to diagnose PCOS, you need to meet 2 out of 3 clinical criteria. And I put emphasis on clinical criteria because there are what we call research criteria out there as set forth by the National Institutes of Health, the NIH in the USA. But the truth is, for a clinical diagnosis of PCOS, in terms of you being diagnosed by a clinician, you need to meet 2 out of 3 criteria. And so those 3 criteria are: 1, history of irregular periods. So for some people, they've had the irregular periods their whole lives, in terms of their whole reproductive life. For others, they've had irregular periods mostly after puberty into their 20s, and as they got older or lost some weight, etc., the periods regulated. And then for others, their periods were regular, and then after a period of change in their life, they became irregular. So you need some history of irregular periods. The second is evidence of androgen excess, and androgen is a fancy medical word for testosterone and testosterone byproducts. So when we're looking for evidence of elevated testosterone, we can certainly be looking for it on blood work, but we can also look for it clinically. So we look at whether someone has a history of acne, particularly acne on the face, chest, back, lower abdomen, inner thigh, upper inner thigh specifically. Or does someone have unwanted excess hair growth on the face, chest, middle of the breast area, back, lower abdomen, upper inner thigh. And thirdly, evidence of polycystic appearing ovaries on ultrasound. But mind you, like I said, we're not looking for cysts. So really what we're looking for is evidence of an abundance of egg houses. So specifically on ultrasound, we're looking to see, are there 12 or more egg houses on any single ovary? Or are we seeing an ovary that doesn't have a big cyst on it that still measures greater than 10 cubic centimeters in terms of volume? Now you need 2 out of 3. So what that means is some people are going to have irregular periods and elevated androgens, and that's their diagnosis. Others will have totally normal periods, but have elevated androgens and evidence of polycystic appearing ovaries on ultrasound, and that's their diagnosis. Others are going to have irregular periods and the ultrasound finding. So what's my point? My point is polycystic ovary syndrome is one of the most confusing things to diagnose because it can take on a different picture in every different person who's diagnosed with it. But I want you guys to recognize what I didn't mention at all, Yashi, in that whole thing about the clinical criteria: weight. We do not use weight as a criterion for diagnosing PCOS. And I feel like that is one of the disservices that has been done to a lot of people out there, because some people who are struggling with weight issues were labeled with PCOS when in fact they don't have PCOS. And then on the flip side, there are people out there who are what we call normal weight or very lean, very skinny, and they have all the characteristic symptoms that meet clinical criteria for PCOS, but they're being told, no, you're too skinny, you don't have PCOS. That's impossible, you don't have PCOS. And of course, weight has nothing to do with the diagnosis. In fact, weight is independent of a PCOS diagnosis. Now, it may be associated with an underlying cause with PCOS or a related cause, because PCOS can manifest differently, or as people call it, different types of PCOS. I don't subscribe to the different types necessarily, because that is still a topic of hot debate. There are different manifestations of PCOS, but in terms of our actual criteria, we haven't specified different types, but I know different types are circulating a lot online, in the blogs, in different groups. But the truth is, they haven't been firmly determined to truly be concrete different types. And the truth is, I'd hate to try to box someone into a type, and if they don't fit, suddenly we'd find they're left thinking, well, maybe I don't have PCOS. But really, it's based on clinical criteria. It's a gestalt of criteria, as we say. It's a combination of criteria. It requires people being very expert at looking at it. Important to know also, PCOS is technically what we call a diagnosis of exclusion, meaning we first have to exclude other things before we land on PCOS. Now, that we can quickly exclude the other things, though. It doesn't need to take 3 months for someone to exclude everything else, or a year or 2 years. But the truth is, we do have to make sure we're ruling out things like what's called HERE-AND syndrome, which is hyperandrogenism, insulin resistance, acanthosis nigricans. We have to rule out something that's going on in the adrenals, where someone can have a deficiency in key enzymes in their adrenal glands that help them break down certain hormones that can lead to what looks like PCOS, but it's actually something else. It could be an enzyme deficiency, very specific sex hormone enzymes that we know about and important to identify, and thyroid, etc. But it's key for everyone to know weight is not a criterion for diagnosing PCOS, even though I see a lot of people out there being told, oh yeah, it's because of your weight, therefore you have PCOS.
Yes, that's so true. And that's usually like the first thing that they tell you to do if you are, a little over your BMI or whatnot. It's like, lose weight and you'll be fine. And what's coming to me, Dr. Cindy, when you're talking, is that to me, like, when I hear stories about women who are diagnosed with PCOS, I've never really heard that level of detail in terms of what you're saying, ruling out certain things. Usually they just say, okay, you're a little overweight, you have the cyst on your ovaries, you have a irregular period, and you're labeled as PCOS, and then you're treated as such. But from what you're saying, it really takes a very thorough approach before you can say that somebody is diagnosed with PCOS.
Correct. And so that initial evaluation requires a complete look at the person, their health history, but also specifically ruling out certain things that can mask or appear to look like PCOS, and which, if we don't identify, can make treating PCOS near impossible, because the truth is that's not what they have, right? And so they're frustrated, and they're left thinking that the health system is failing them because they were given the wrong diagnosis. So it's really important. I love doing talks like this because I want folks out there who've been diagnosed with PCOS to really ask themselves, do I have 2 out of 3 criteria? That's the first. The second is, if you don't have 2 out of 3, but they still told you, oh, but you're overweight, therefore you fit, that is not good enough, because there are other things that can have weight issues. Mind you, not everyone with PCOS has weight issues, like I said. Only about 40% really of PCOS patients, it's not only, it's a significant number, but the majority of PCOS patients are either what we call normal weight or very lean. And oftentimes those people, the very lean ones, have really difficult PCOS, but they're left living without a diagnosis. I think we saw it recently with the actress Keke Palmer, who shared that for years she'd been having symptoms and only now she's been diagnosed with PCOS. And I strongly suspect it's because for those years, she's someone who lives on the leaner side. And so people dismissed her complaints, which is such an unfortunate thing. But going back to your question about the things that it could be other than PCOS, yes. And I think, unfortunately, a lot of clinicians out there only learn the basics about PCOS and have forgotten that key tenet about the diagnosis of PCOS, which is it's a diagnosis of exclusion. First, you exclude everything else before you land on it. But again, if you're someone who knows how to evaluate a person, you can do all of that workup and have all their answers between the first time they visit you and the second time they visit you. And that's how quickly you can have answers for your potential client who has been diagnosed potentially with PCOS but needs confirmation. Now, once you've confirmed the diagnosis, then you need to look at what else is going on for them. Do they have a predominant inflammatory presence with their PCOS? Are they having issues with digestion, with their immune system? Are they having issues with sugar or glucose metabolism? Specifically, do they have insulin insensitivity, or what we also call insulin resistance? Or are they diabetic? Do they have issues with their blood pressure? Do they have issues with their heart rate, their cholesterol? Because the truth is, when your hormonal system is trying to adjust for what it's seeing going on with these high levels of androgens, etc., it starts adjusting everything else, and those in turn can lead to a host of problems, like damage to your blood vessels, where cholesterol then deposits, and now you've got problems where your vessels are hardening, or your heart is having to pump faster and work harder against that. Higher blood pressure results. Or maybe the person has insulin insensitivity, meaning their pancreas is working really hard whenever they eat a glucose load, but the cells aren't actually seeing the sugar because they're not taking it in, because they don't recognize the insulin that usually tells your cells, hey, pick up this sugar from the blood. And so it's important to know that kind of stuff, because you can help someone, you can help them reverse PCOS actually, if you identify what's their PCOS specifically.
And when you say reverse, doc, kind of give us a little bit more information in terms of that, because you always hear that PCOS is not curable. You have to really live with it and that sort of thing. When you say reversible, what do you mean exactly?
Yeah. At present, unfortunately, PCOS is not curable. I know there are many people out there who are marketing things that say they can cure PCOS. I really caution anyone not to believe that. The truth is, though, you can reverse PCOS and therefore you can live as if you cured. But the truth is, if you ignore PCOS or you ignore all the parts of your PCOS, unfortunately, PCOS is not just pubes and boobs. It's not just your breasts and your periods, right? PCOS is a multi-system, complex disease state that can lead to damage of lots of different parts of your body if you're not careful, that can be permanent, so that you can have heart problem that persists well past menopause. And that's why persons with PCOS have higher rates of heart attack and stroke compared to those who didn't have PCOS. It's why persons who were diagnosed with insulin resistance, i.e. insensitivity, I prefer to say insensitivity, of PCOS, go on to develop type 2 diabetes at higher rates. And so ignoring it by saying you're curing it means that you're really putting yourself at risk for one day waking up and being told, oh, you have diabetes, when you could have reversed that and actively taken steps to change lifestyle. So, what are those reversal steps? Well, it depends on what your PCOS is. So, for example, if someone has sort of what we call the inflammatory dominant PCOS, then I talk to them about things like, what are you eating? How are we increasing your prebiotic, probiotic, and postbiotics in your diet so that we can really support your gut microbiome. Believe it or not, your gut, your intestines have the largest part of your immune system outside of your bone marrow. And so it's really important that we support that. In addition, similarly, in terms of how you break down certain foods, how you control hunger, and therefore control two key hormones that are usually originating from your gut that go to your brain. One is called leptin, one is called ghrelin. Ghrelin, just like it sounds, ghrelin. It's that hungry hormone, right? It's the hormone for a lot of our PCOS patients is what sort of drives when you feel hunger. You know that hunger that your brain actually causes you to feel pain if you don't eat? It's ghrelin doing that. And so we have to address and identify that. And there are ways to do that so that we can downregulate those hormones. And in turn, one, you feel satiated, meaning you feel fuller sooner, so you're not hungry all the time, because it's a real phenomenon. It's not that you have bad ways, it's not that you're greedy, it's just there's a hormone that's driving it. And so we have to actually work on the hormone to get that under control. The same thing happens for if you have like the insulin resistance, right? What are we going to do to work on your muscles becoming more sensitive to insulin, given that it's your muscle cells that actually pick up most glucose from your blood? And and until your muscles do that, your brain is going to keep thinking it's starving. And what does that mean? If we don't identify that in you, even if you're trying to be fit and healthy and you're going to the cardio classes and you're doing all the fad diets that your friends are doing, if you're not addressing what's happening at the level of your muscles being insulin insensitive, what happens is your pancreas keeps working hard. Eventually, your pancreas is going to become fatigued. And that's how you end up becoming diabetic and even insulin dependent. It's not because you suddenly develop type 1 diabetes. No, it's still type 2. But you now have an insulin dependent type of type 2 diabetes because your pancreas is exhausted. It's been working so hard for years to keep up and overcome that insulin sensitivity in your muscles. So for patients like that, we're talking about the specific exercises that work for PCOS, exercises that are different from what most of your friends and family might be doing, different from what the starvation type diets out there want you to do. Because with PCOS, particularly if you have insulin insensitivity, insulin resistance, if you starve yourself, remember, your brain already thinks you're starving. If you starve yourself, your brain now thinks, okay, you're trying to kill us. I've got to keep us alive despite your attempts to starve us, because it hasn't been seeing sugar. So what does it do? Now it really holds on to the fat you have stored, the energies that you have stored, because it's trying to preserve the organism. So instead, I work with patients and our nutritionists and our fitness specialists who are certified to treat people with PCOS. We work with them so that they can come up with a diet plan where they're never feeling hungry, but they're not starving. Because again, that starvation cue is the last thing we want going to your brain if leptin and ghrelin are already high. And so it's working on that, working on exercises that focus on fat burn, that focus on resistance training. That's the sort of thing we do to reverse it. And you'd be surprised how many people are able to reverse and just live once they come to terms with their PCOS and what is their PCOS picture.
Oh, thank you for that information. I was like, when I think about what you're sharing, you don't get that type of information when you're diagnosed. In fact, from what you're saying, you could possibly be being diagnosed as PCOS and it's something else, and you could be treating it the wrong way for so long. But what is your opinion in terms of how the culture is changing? Because we have, shows like this, we have My Dynamic Uterus and these things. Do you feel like there's going to be like a change in terms of how persons approach PCOS?
Absolutely. There's also tremendous advocacy at the level of decision makers the world over. We need more advocacy, though, which is why I love doing things like this, because the more people in the general population we get talking about this, the better. I mean, this is why my dynamic uterus was started. I started this movement because, first and foremost, we need to normalize conversations about period health, womb health, hormonal health. The truth is, for many of us, we're growing up in families where multiple people have the same thing. Believe it or not, PCOS is genetic. A lot of the other people in your family have PCOS, and even the men in your family, like your dad, will have some aspects of PCOS, obviously not the ovary, but he has other factors driving it. So it's not uncommon to meet someone with PCOS, especially if they're the one that also has insulin insensitivity, etc., to discover that there are family lines of people with type 2 diabetes, and the severe type of diabetes, the ones where family members are losing limbs and stuff, because again, they're the insulin dependent type, because there is a certain level of pancreatic fatigue that's coming in, right? These are the people for whom, even with bariatric surgery, meaning the surgery where you lose tremendous amounts of weight, their diabetes may be better controlled, but they're not necessarily cured of diabetes, because it's not simply a weight driven process. There's a genetic side to it. But it's really important that we have these conversations. The more we talk about it, the more people will realize, oh, so you're telling me if I don't have a period every month, I should be talking to somebody about this? Yes. Unless you are on something that is intentionally keeping your period away every month, whether it be some form of hormonal contraception, maybe you've had an intrauterine device placed or something, or a Nexplanon, the implants in the arm placed. If you're not on any of those things and your periods come irregularly, someone should know about it. You should be talking about this. If you are someone whose periods come too regularly, meaning they're like twice a month, and when I mean twice a month, like an interval less than 21 days apart, that's something to talk about. If your periods are heavy, so many of us, especially women of color and women of Afro heritage, we were raised in households and family units where everybody has heavy periods. And so we were told heavy periods are normal, when in fact they're not normal. We should not be losing more than 80 milliliters of blood per cycle, for a whole cycle. For a lot of us, we lose that much in one day of our period. That's way too much, which means we're going around in a constant state of anemia, which puts more strain on our heart, more strain on our brain, trying to keep up with everything, and decreased blood supply puts a lot of strain on our bone marrow, where our red cells are made. So we end up making lots of platelets and other things as our bone marrow tries to keep up with the blood loss, and that can lead to strokes and so forth also happening. And then lastly, in someone who has irregular periods like PCOS, we know it's one of the biggest risk factors for uterine cancer, for womb cancer. And so this is why I started My Dynamic Uterus, because I want people to have these conversations. I want more people of color especially to know that we shouldn't be normalizing the abnormal, and we should also be empowering our young people, our family members, to talk about these things, to talk about painful periods, that we don't dismiss them by saying, but what are you trying? Everybody else in this family been having periods for decades. Why are you special? No, the truth is, at some point we need to stop it. And so I am happy that more and more people are talking about PCOS nowadays. I think it's a step in the right direction. It can only empower our next generation. It's not going to hurt them, it empowers them. And I am really excited because not only are we having the conversation at the level of the potential patient and their community, but we're also having these conversations amongst our trainees in medicine, because we also need to educate, right? More clinicians, because like I said, there are many people who are falling into one of two big categories. They're either being told they have PCOS simply because they have a weight issue, and that's not fair to them. But also there's a really large cohort of PCOS patients who, because they're slim and because there's been this misconception that only overweight people have PCOS, all these slim folks with PCOS are being ignored or dismissed and having delayed diagnoses, which is also not good. And so talking about it helps, and it's definitely making a big difference already. We have a long way to go. We're yet to have large PCOS centers around the world. Yet PCOS affects women and people born with ovaries from every population on this sphere that we call Earth.
Oh, wow. Dr. Cindy, when I think about it, I'm first of all, I think I feel a little bit disheartened that we took so long to get to this point, but then still excited that, where we have to go, and what from the summit that I really was encouraged by is that the women who are now advocating and talking about it are the persons who have been through it and had was told just to lose weight, and they're now looking for ways to really embrace the uterus fertility and teach other persons. So I have a lot of hope that and persons like yourself as well who are sharing every week, every day with persons talking about it. I mean, I learned things from you that I didn't learn, and I had PCOS since I was 18 and I'm 34 right now, but I just have hope that it's going to help persons in the future. I did say persons could ask any questions, but I don't see any. Okay, I see one from Sarita saying, what about irregular cycles when on an IUD? Is that normal?
It depends on the IUD. If you're on an IUD, so it's not really on, but if you have an IUD in place that is secreting low doses of progestin, which is the type we like, so that's either Mirena, Kylena, what other name could it be? But those are the ones that usually the goal is for you to become amenorrheic, meaning no period while the IUD is in place. So for that low dose progestin secreting IUD, when they're usually in your womb for up to 5 years, 80% of people who have it in place will be amenorrheic, meaning have no periods by 1 year in of it being placed. 80%, meaning only about 20% will have a period, and it might be very light and very irregular, and that's normal. So that's why I said it's only if you have irregular periods without these things in place. But a Mirena IUD is normal. Usually the other type of IUD out there is the copper IUD. The copper IUD generally doesn't lead to your period spacing out. You should still be having a period every month. So if you're someone with a copper IUD and your periods are very regular, then you could probably have a conversation with your specialist who placed it about the copper IUD. But the reason why we love IUDs, I'll tell you why, no matter what kind. With IUDs, you still ovulate, so your ovaries are still functioning. There's no suppression of ovarian function. They both work, one way that they both work similarly is that they physically prevent implantation. But in terms of the Mirena IUD, for example, the Kylena, the Skylar, the ones that secrete low doses of progesterone or progestin hormone, is they also keep the lining of the womb thin. They thin the lining. And so what's nice about that is it also doesn't provide a place for implantation to occur, even if an embryo were to make it past the physical presence of the IUD. But secondly, in someone with PCOS who, like I said, is at increased risk for having uterine cancer, because generally a subset of PCOS patients don't ovulate regularly, which means estrogen just keeps building up in their system and their womb lining keeps growing in response to estrogen, and the cells there can change and become a cancer. Having the progestin in place really helps to protect the lining of your womb and thereby decrease your likelihood of developing a cancer in the womb lining, which is endometrial cancer. And so that's really helpful. And then for those who maybe were diagnosed with early stage, either hyperplasia, which is endometrial precancer, or they were diagnosed with an early cancer, but still desiring fertility, we usually use things like the progestin IUD to help thin the lining, reverse the cancer, and then get you pregnant real quick so we can use your uterus before you can't have it anymore.
Thank you for that. Let me just check to see if there's any other questions. Guys, if you have any other questions, you can ask now, Dr. Cindy. In the meantime, I just want to say Thank you so much for joining me here and for all that you're doing in terms of sharing the information for the community. I heard your Trini roots a little bit when you said bad ways and
Right? Yes. So I was born and raised in Tobago. So
Mhm.
I'm from Tobago, went all the way through high school in Tobago. And then we immigrated to the US and I attended college and beyond here. But yes, my navel string is firmly planted in Tobago and Trinidad and Tobago, yes.
So I see just one more question from Sarita. She said, "Do you recommend the HPV when you're younger?"
I do. I recommend, well, full disclosure, I have a PhD in virology. I feel very strongly about what viruses can do in our body, specifically human papilloma virus, HPV. There are 4 types that cause almost 90% of all cervical cancers. Cervical cancer is still the leading cause of cancer death of women around the world. In the United States, it's the 3rd or 4th leading cause of cancer death because we've done such a great job in the US in terms of pap smears and making sure everyone gets their pap smears and having our guidelines. And now we do co-testing, but also because we've been vaccinating. So vaccination against human papillomavirus, specifically the 4 types that are known to cause the majority of cervical cancers in the world, will decrease your risk of developing cervical cancer. But it's not just about cervical cancer. So HPV, these types of HPV also cause throat cancer. So if people are engaging in genital oral contact, if you got your HPV vaccine, it's also going to prevent throat cancer. These particular viruses also cause penile and anal cancer. Most people don't know this. And so this is why we recommend vaccination for both boys and girls. And ideally, we want to do it before they ever start experimenting sexually. And so that's why we recommend it be done somewhere around age 9 and 12, because sexual debut happens fairly early, whether we like to admit it or not. Sexual experimentation doesn't just include the things that we want to consider sex, which is how to make a baby. There's genital oral contact, there's people using their hands, touching things, etc. Those are all ways that they can still spread this stuff. And so, yes, I recommend it. It is a safe vaccine. I really don't get into the controversy that's really out there by the anti-vax movement, but HPV vaccine is safe and strongly recommended. And it's not just recommended now for preteens and adolescents, it's recommended for everyone. So your college age student, if you're in your 30s, you can also get the vaccine. We're certainly recommending it also for our older folks who are in their 50s, right? The postmenopausal group, because usually that's the group that has high rates of either divorce, widowship. And so they're now returning to the sexual market, so to speak, in terms of dating, etc. And the highest rates of sexually transmitted infections outside of people in their 20s and teens are those who are 55 and older. I don't know if people know that. So we do recommend it there too.
I didn't. I mean, you effectively answered her other question because she was asking if we are ever too old to get it. So you just answered that one.
Oh, no, yeah, I didn't see that, but no, not anymore. In the beginning, we were really recommending it for younger folks, but now we know the benefit extends well beyond those ages. The bigger issue is whether your insurance will cover it after a certain age. And so at that point, I would say it's an investment, right? If your insurance doesn't cover it, or if you're in a country where there isn't a concept of insurance and it's more going to a private clinic to secure it, then pay for it out of pocket is well worth it, particularly if you're either on the market and dating, or if you're not sure that it's only 2 people in your relationship, you should be getting it.
Okay, so I see just one more question, Dr. Cindy. From Laura, she says, what's the step when you now find out that you have PCOS and you're missing your cycle?
So the first thing I do with someone who has PCOS and is having an irregular cycle is figuring out why. So the one thing I want people to know is you can have PCOS and still have other things going on in your body. And so we're going to double check to make sure your thyroid is functioning well. If you happen to be someone who has issues with weight, particularly not just weight, but body fat, because someone can be very sturdily built, but be quite lean actually, right?
Mm.
If we look at our bodybuilders, our extreme athletes who build a lot of muscle, they weigh a lot, but they don't have a lot of body fat. So the truth is, particularly if you're interested in reproduction, meaning if this is a question related to fertility, your body really functions best between 12% and 30% body fat. And that's the ideal range we think, but we know for each person that varies a little bit. So for example, I have patients with 18% body fat and it's still not enough. We got to get their body fat percentage up into the 20-something% before they start having regular periods. Similarly, someone may be around 30%, but their brain has a set point, a threshold of 28%. And so really I need to pull their body fat percentage down and then their periods will be regular. So rule of thumb though, what we say to people is if you lose between 5 to 10% of your body fat, that the majority of people with irregular periods will start seeing some regularity returning. That's if it's a fat issue. Now, like I said, PCOS is a diagnosis of exclusion because there are groups of people for whom it's not PCOS that they have, but they have something known as hypo, which is hypothalamic hypopituitary hypoovarian syndrome, where it's that their brain has stopped talking to the ovary. And so in someone like that, some things we do may help overcome that, but for others, the only way to help you have regular periods if you're trying for fertility, meaning ovulate, is to give you injectable versions of the hormones your brain should be making, which is FSH, follicle stimulating hormone. But again, this is why I keep saying PCOS is a diagnosis of exclusion. I think way too many people are told they have PCOS without everything being ironed out, figured out, and they're left for years with that struggle and that confusion when the solutions are there if only they got the right diagnosis sooner.
I know you kind of touched on this, but Lavinia asked again, can I pass PCOS to my future daughter since I have it?
PCOS is genetic, so there's a very high likelihood that your daughter would develop PCOS as well. There's no way to prevent genetics at the moment. Even with in vitro, we don't have tests to identify things like PCOS and diabetes. Those are what we call multi-gene, multi-genetic diseases. So there are environmental things, of course, but there are also certain genetic factors, some of which we're still learning. But yes, you can see PCOS in your daughter. Key to anyone who might be wondering if their daughter right now has PCOS is we don't diagnose PCOS in the first 2 years from menarche, meaning the first 2 years following that first period. And that's because it does take 2 years or so, 24 months, for that conversation that's supposed to happen between the brain, the ovary, the adrenal glands, and even your fat cells. Because believe it or not, your fatty tissue in your body is a hormonal center, right? Mm-hmm. That is a big hormonal center, adipose tissue. So it takes 2 years for what we call the HPOA, right? So that's the hypothalamic pituitary ovarian adrenal axis. It takes a good 2 years for that to mature. And okay. So if someone is in the first 2 years of having started their periods, they may have irregular periods, and that is completely normal and totally unrelated to PCOS necessarily. So we do not diagnose PCOS in the first 2 years. Following menarche, we monitor. If there are other signs, acne, etc., again, we monitor because it takes 2 years. So it's not uncommon to see someone who is pubescent with acne issues. Some people, they have extra hair growth, but it's really more of the family, right? And the family hair growth is extra. And so we look at all those factors before we call it PCOS. But that's my long-winded way of saying, yes, it can pass on to your daughter. But in her first 2 years following her period, we wouldn't call it PCOS until we're sure. And so we have to wait 2 years.
Okay, great. Well, thank you again, Dr. Cindy, for all the information you shared today. I guess you could probably just share with the persons like how they can reach out to you, how they can find out more about my dynamic uterus and so on.
Oh, absolutely. Well, I'm across all social media. So you can find me at Dr. Cindy M. Duke. So DrCindy, M as in Mary, Duke, all one word. So Dr. Cindy M. Duke, I'm across you name the platform, I'm probably there. Twitter, YouTube, Facebook, Instagram, Pinterest. I'm on LinkedIn. You can also look me up on the drcindyduke.com website, and there I have blogs, including some handy dandy things to help with PCOS. And then mydynamicuterus.com. My Dynamic Uterus was first launched as a Clubhouse community. So for those who are on Clubhouse, definitely check us out there. If you're not yet on Clubhouse, I have thousands of invitations. So whether you have an iPhone, iPad, or an Android device, you can join us. We do a room exclusive to PCOS every Wednesday in the My Dynamic Uterus Club on Clubhouse. We are actually the largest pregnancy and fertility focused club on that app. And so we talk about PCOS for 90 minutes every week. It's a Q&A where anyone can come on stage and ask their questions and get a multidisciplinary answer. So it's myself, other OBGYNs, nutritionists, fitness professionals, advocates, mental health specialists. We also have Dr. Sylvia Bolson Gonsan-Boli. She is an obesity medicine specialist who focuses on healthy ways to achieve lasting weight loss. And so mydynamicuterus.com, but also My Dynamic Uterus on Clubhouse. If you need an invitation, message me. We have thousands of invitations for anyone who'd like to join us. That's every Wednesday at 7 a.m. Pacific, which would be 10 Eastern and 10 Atlantic Standard Time.
Yes. Oh, well, Dr. Duke, they're thanking you so much for answering your question. And again, I thank you. And I just thank you not just for joining me here, but for everything that you're doing across all those platforms. It's so helpful and it's so needed right now. So I'm so grateful for you.
Thank you for having me. And I'm glad I made it on. The phone worked well. So this is good. I'm happy.
Yes, and I'm sure that you were so helpful to all the ladies who are tuning in and who are going to tune in after.
Thank you. Happy Monday, everybody. For those in the U.S., happy Memorial Day. And for those who have lost family members in the service of others, thank you for their service and their sacrifice.
Mm-hmm. All right, Dr. Duke. Thank you again. Bye. And guys, that was Dr. Cindy Duke. As you can see, she is just so amazing and she is so helpful. And I encourage you guys to reach out. If you can go on Clubhouse, definitely join there because I learned a lot, and it was the reason that I wanted to connect with her when I heard her speak about PCOS and then heard about her trini roots as well. So please do connect with the persons that are on this summit. There are, as from what she's saying, yes, it does sound sometimes a little daunting dealing with this condition, but as she's saying, if we figure out what's going on with us, there are solutions. You can take these steps as necessary. It's not hopeless. It's actually very hopeful. And when you have persons like that who you can connect to, and all the ladies who are on this summit, it's a step in the right direction. I see things changing. So we just need to, just have that moment, take that moment, figure out what's going on, take these steps that we need, reach out to these people, and let's figure this thing out together, right? And find out all the information that we need to and take the right steps. So to end on a happy note, I have a great announcement. One of the lovely speakers, Amanda Rupnarayan, she is the founder of Alchemy TT, and the concept of that company is energy infused beauty. She talks about harnessing your energy as well as manifesting internal peace and abundance. If we have a wonderful talk in store for you, that will be released on the last day of the summit, and she has graciously given a special for this week, just for the week of the summit, 10% discount store-wide on her products. So check them out, Alchemy TT on Instagram. When I send out the email later, I will share the link. But check out her store, check out the wonderful products. And yeah, so and tune in tomorrow. Tomorrow night I have a very special guest here at 8:30 AST. To the theme of tomorrow is fertility and menstruation. So right after I come up here, I know I said 9 o'clock I'm gonna release the other videos, but it's gonna be a little late. It's gonna be a little 10 o'clock. But you're gonna get them. And there's 7 wonderful chats with wonderful ladies on fertility and menstruation. And if you thought day 1 was good, day 2 is going to be just as amazing. Trust me, you're going to learn so much, and I'm so excited. And we have a giveaway, a special giveaway tomorrow night. But you need to be registered for the summit, and you need to be here live to qualify for the giveaway. Okay, and a little clue is that pay attention to the recording with Maudlin Francis, the creator of Lily and Fee, and the benefits of sustainable solutions is what we're talking about. So pay attention to that one, and that's my little clue for the giveaway tomorrow night. So thank you, ladies. Thank you for engaging. We're here to do this together. So much information, so much we need to do, so much we need to learn, but we can do it once we have the information, and as I say, we take the right steps, and we have this support system. We can do it, guys and ladies. Okay, you're welcome. Alicia. Alicia is another wonderful speaker who we're gonna have on day 3. So that's gonna be the release tomorrow night on herbs on PCOS. So you look out for that as well. And yes, so thank you guys. Look out for my email. If you haven't registered as yet, what are you waiting on? You see the kind of content we have with people like Dr. Cindy Duke, and all the lineup about the speakers is so amazing. So you need to hear from them, and we really need to embrace our womanhood, embrace our fertility, embrace our uterus, embrace everything that makes us a woman, and we can definitely manage PCOS, conquer PCOS, and whatever other condition that we might be dealing with. Okay, so bye. I kept you guys long enough, almost a whole 15 minutes. So let me let you go. Have a good night, and see you guys live again tomorrow, 8:30 AST. Bye.